Good morning, dear students. Today we are starting another very important topic in pediatric neurology, cerebral palsy. Cerebral palsy, otherwise commonly known as CP, has been defined as a non-progressive injury to the immature brain leading to motor dysfunction where lesion is not progressive but the clinical manifestations change over time and mainly affecting the movement and posture. So leading to when they say leading to posture movement dysfunction, it is affecting movement as well as posture. So we can define it as a non-progressive injury to the immature brain. It is always happening to a which is non-progressive, and the because we are talking about the lesion which is non-progressive. So and leading to motor dysfunction which will affect the movement and posture, and clinical manifestations change over time. So some of the conditions where the conditions may be look similar to CP are progressive disorders resembling CP. So there are progressive disorders which are resembling CP and non-progressive disorders resembling CP or cerebral palsy. The progressive disorders resembling cerebral palsy are type 1 arginase deficiency, Sjogren-Larsen syndrome, Lesch-Nyhan syndrome, Chiari type 1 malformation, Dandy-Walker syndrome, and Angelman syndrome. The above mentioned problems, syndromes, or disorders, children who have those will commonly look similar to CP. Most commonly, everyone will mistake that the children with these conditions belong to cerebral palsy. It's a group of disorder. It's a cerebral palsy, may be similar to the above given progressive disorders resembling CP. Some non-progressive disorders resembling CP may be mental retardation, deprivation leading to malnutrition, non-motor handicaps such as blindness, which may lead to movement dysfunction, which may look like cerebral palsy. Kids, motor handicaps usually due to conditions such as spina bifida, myopathies, and muscular dystrophies. So these kind of conditions may resemble to CP. So what are the risk factors? Risk factors are mainly prenatal, natal, and postnatal. So risk factors, many risk factors are there. The important one I am giving here. In the risk factors, prenatal risk factors, prematurity is a big risk factor. Premature child, preterm delivery is a common risk factor. Any delivery with less than 36 weeks of conception is a preterm delivery, and this preterm delivery is considered to be the biggest risk factor for cerebral palsy. The other risk factors in prenatal conditions are low birth weight, which is less than 2.5 kilo. In that 2,500 grams, we know that there are three categories of very low birth weight, moderate low birth weight, and what you call as mild low birth weight, mild LBW we call it as. So those belong to anything below 1,750 gram is called as very low birth weight. That is severe low birth weight. So and between 1,750 to 2,000 grams are considered as moderate low birth weight, and between 2,000 to 2,500 grams are considered more what you call as mild low birth weight. So according to the categorization of the severity of low birth weights, we the complications will also be severe. So other when we look into the other risk factors, maternal epilepsy, the mother is if the mother is the epilepsy patient, the chances of child being cerebral palsy is higher. Infections, common infections are torch infections, which toxoplasmosis, rubella, cytomegalovirus, herpes simplex, that is called as torch. We put in a simplified form, short form torch. So these infections such as toxoplasmosis, rubella, cytomegalovirus, herpes simplex are common infections which can lead to infection to the maternal mother can lead to cerebral palsy to the child. Bleeding in the third trimester, the third quarter of conception, bleeding, if that bleeding happens to the mother, then there's a possibility of cerebral palsy. Severe toxemia, severe any kind of intoxication, any kind of toxin has to be taken by mother is common. Eclampsia, any vascular eclampsia disorders, multiple pregnancy, numerous. The mother's age is more, and the mother has undergone a lot of pregnancy, and the health condition is totally not healthy. Then these can also lead to the child being cerebral palsy. Placental insufficiency, the placenta, which is a major the life giving giver for the child, because all the nutrition and all the physiological functions, all the oxygenation, everything is done through the placenta. If at all there is any insufficiency of the placenta, that is going to lead to cerebral palsy. All these are in prenatal. In drug abuse or trauma to the mother, any kind of drug abuse, or so most of the prenatal causes, or what we are talking about, is the mother, the what is the related to mother. Okay. Now perinatal means otherwise called as during the delivery or the course of labor, whatever happens, a prolonged and difficult labor, what is called as prolonged labor or difficult labor, is going to be the cause for cerebral palsy. Premature rupture of membranes, premature rupture of the membrane in the first stage of the labor. The rupture of the membrane is, if it is premature, then the labor stages are again, it will go into prolonged labor. So again, what you call as asphyxia may happen for the child, and oxygen will be cut from oxygenation of the brain will be affected. So that will be leading to asphyxiation. So prolonged labor, all those cord around the neck, presentation of an anomaly, that is a breech presentation, vaginal bleeding at the time of labor, bradycardia and hypoxia. So all of this will lead to bradycardia and hypoxia for the child, and this will lead to hypoxia of the asphyxiation for the child, and the hypoxia or ischemic hypoxic attack of the brain, leading to cerebral lesions. Postnatally, mostly it is due to infections to the central nervous system. Infections such as encephalitis, meningitis, or the common cause. Neonatal hyperbilirubinemia, anemia, otherwise called as kernicterus, which is due to increased amount of bilirubin in the neonate. The neonate is the child we call in the first month or 28 days of age, we call the child as neonate. And postnatally, during this neonatal stage, if at all there is a head trauma, or the child has neonatal seizures, or the child has any kind of what you call as coagulopathies, means clotting disorders. All those are the five important uh, risk factors for postnatal cause for cerebral palsy: CNS infections, neonatal hyperbilirubinemia, head trauma, seizures, and neonatal seizures and coagulopathies. So, how will we classify cerebral palsy? During diagnosis, the classification can be happen due to type of the muscle tone. Variations, abnormal muscle tones are the common factor. We have understood that it affects movement and posture, meaning that it affects the muscles. So, tone of the muscle tone is important, and according to the muscle tone, we understand that the lesion should be in this area. So, if you see here, the muscle tone variations abnormality is given as spastic cerebral palsy, dyskinetic cerebral palsy, hypotonic or ataxic cerebral palsy, or mixed cerebral palsy. This is according to the classification, clinical classification. It is not a topographic classification, it is a clinical classification according to the muscle tone. The muscle tone variation may lead to spasticity, dyskinetic abnormalities, hypotonia, ataxic cerebral palsy, mixed. In mixed, it will be the combination. It will be difficult to identify that whether the muscle tone is spastic or ataxic, that is hypotonic, or choric arthritosis or not choric arthritotic. So those kind of this thing muscle tone changes. Some children will have combined. They will show spasticity in one area and maybe the lower limb, and they will show hypotonia of the trunk. So these kind of clinical presentation in abnormal muscle tone can be classified as the above mentioned. So if it is spastic condition, then we can understand that the lesion site is in the cerebral cortex. If it is dyskinetic or what we call as any kind of dystonic problems, it may be related to the basal ganglia. Hypotonic and ataxic is mainly related to cerebellum. A mixed, when we see mixed kind of tone variations, it will be usually the lesions will be in most of the sites, all of these sites or some of these sites. So how will we classify anatomically, or what I like to call it as topographic classification? The classification or the it depends upon the representation. So hemiplegia is the type of cerebral palsy where the upper and lower extremity on one side of the body is affected. So defining hemiplegic cerebral palsy means the same side upper and lower extremity is affected. In diplegia, four extremities are affected. All both upper limb and lower limbs are affected, but legs are more affected than the arms. That means that it is similar to quadriplegia, but here the upper limbs are far better. But mild impact will be there, but lower limbs are, so we can call diplegia upper limbs are less affected. The better way to say that upper limbs are less affected than the lower limbs. In quadriplegia, all the four extremities are affected. Also, the trunk, neck, and face is also affected. That means that the whole body is affected. All this abnormal muscle tone will be evident throughout the body, so no part of the body is exempted or normal. Triplegia, which is very very uncommon, rare, but both for the purpose of studying it, you can understand that triplegia, both lower extremities and one upper extremity is affected. So here you can see triplegia and diplegia is a variation of quadriplegia. Most of the time we can't find a pure triplegia. So triplegia is a quadriplegic patient where one upper extremity or one lower extremity, child is able to have some kind of capability, motor capabilities. Monoplegia, very very rare. I have my own experience. I have never seen a monoplegic cerebral palsy child. Even after seeing number of at least 1,000 cerebral palsy kid children sitting, after seeing them, I have never seen a monoplegic patient. But for study purpose, we have to understand that maybe somebody somewhere it has existed. So that's why one extremity very very rare. Double hemiplegia, so in the next one is double hemiplegia. After monoplegia, that is four extremities are affected, more arms and more affected than the left. So the rare cases. So I just have to tell you that triplegia, monoplegia, and double hemiplegia are very very rare. I have not personally have not seen any such cases. Now going to each and every type of CP in detail. Spastic cerebral palsy, which is the most common cerebral palsy. So spastic cerebral palsy, usually it can be a spastic cerebral palsy, hemiplegia. So we will call spastic diplegic cerebral palsy or spastic hemiplegic cerebral palsy, or we call spastic quadriplegic cerebral palsy. So basically, what is a spastic CP child? The problem. Increase in physiological resistance of muscle to passive motion. So spasticity as itself is when we define spasticity, it is increased resistance to velocity dependent passive movement. So when the velocity of the passive movement increases, the resistance increases. That itself is the definition of spasticity. So that will be here common here, and it is a part of, it is going to be upper motor neuron problem. Two things will be very very significant. If you test a DT, deep tendon reflex, hyperreflexia, and then movement, you will see clonus, that is repetitive contraction relaxation of the flexor muscles, either of the upper limb or of the lower limb. Then extensor plantar responses and persistence of primitive reflexes are common in